So good evening, everybody. I'm Professor Sanjeev Bhoi, Professor in Department of Emergency Medicine at AIIMS. And welcome to this clinical grand round. And today we'll be focusing on very important topic on block on arrival. The concept generated, we know that, is one of the most commonest complaint in any emergency room is the pain. And it is often overlooked, and many of the clinicians, they use various types of methods to address pain. By ignoring pain is the most important thing they do, and leading to oligoanalysis. And the patient leads to huge amount of patient dissatisfaction despite performing a lot of procedures, doing investigations and all. So to address and make a good emergency department with quality emergency care service, one of the benchmark is to have a pain-free emergency department concept. With this concept, we started working a decade and a half ago. So today we're going to present how it can become a stepping stone to patient-centric care. I'll invite Dr. Ankit Sahu, Assistant Professor in Department of Emergency Medicine, and Dr. Satyendra Mina, Junior Resident in Department of Emergency Medicine, to take you through the journey of a pain-free ED with evidence-based approach, which was the evidence was generated within the department over a decade and a half. Over to you. I invite Dr. Ankit.
Thank you, Dr. Bhoi sir. I am Dr. Ankit Kumar Sahu. So, what we'll be going through is like block on arrival, how ultrasound guided nerve block changed our practice, redefined the pain management in our emergency department. So, what is ultrasound guided nerve blocks? Nerve block is one of the component of multimodal pain management in the emergency department, and peripheral nerve blocks under the guidance of ultrasound, which is the standard of care today. What ACP, that is American College of Emergency Physicians, says is that acute pain is the most commonly and frequently encountered complaint in the emergency department, and the ultrasound guided nerve block is a core component, as well as it is a opioid sparing best practice available for managing pain in the emergency department. Why so much about the opioids? As we all of us know that worldwide the opioid epidemic is going on, and it was found in a 2024 meta-analysis of 22 studies that the patients who are being discharged, the proportion of patients who are having a persistent opioid use is around 8% in trauma and non-trauma cases. And it is also said that emergency physicians, if trained, are competent enough to give ultrasound guided nerve blocks in the emergency department. Coming to what Dr. Bhui has told us, that over the last 15 years, there are multiple departmental research that has been conducted on ultrasound guided nerve blocks. First off was published in 2010 and 2012. In the 2012, this was an article which was published on feasibility and safety of ultrasound guided nerve blocks in the limb injuries in the trauma emergency department, where it was found in 50 traumatic limb injury patients, it was found that ultrasound guided nerve block was not only feasible but also safe as well as efficacious and helped in reducing the length of hospital stay. The next article, which is ultrasound guided serratus anterior plane block for rib fractures. This was a case series which was published 6 years back, where the patient who is presenting with more than 3 rib fractures with intractable pain. For example, the patient who is not getting pain relief with IV opioids and IV analgesics were given ultrasound guided serratus anterior plane block, and also it was found that it was feasible as well as safe in controlling the pain in rib fractures. Following which, there was a chapter that was published about pain management in the emergency department, where we added ultrasound guided nerve block as a newer modality of pain management. Apart from the traumatic injuries, there are multiple case reports that has been published from our department, like in cardiac arrest. The patients presenting with ventricular storm or ventricular arrhythmia. So we have given stellate ganglion block in more than 16 patients, and these are 2 case reports which is showing that stellate ganglion block was efficacious in blocking the refractory ventricular arrhythmia in the emergency department. Apart from that, there are 2 other case series which were like erector spinae pain block for acute pancreatitis pain, which we will be discussing. And one recently published 1 month back, one article was about lumbar erector spinae block, which was used for controlling the pain for a lumbar back pain which was not getting controlled with IV NSAIDs and IV opioids. So this was the assessing clinical impact. For last 2.5 years, we conducted a retrospective analysis of all the nerve blocks that was conducted in our trauma emergency department, and a total of 323 patients were included in this study. And in this retrospective analysis, we have found that for indications like pain, reduction, debridement, and other orthopedic procedures like reduction and debridement, the ultrasound guided nerve block helped a lot. It was feasible as well as safe, and this was the paper which published. After that, we conducted we are in the process of doing various research on ultrasound guided nerve block. So today we'll be discussing two important research work that has been conducting in our department. One is pericapsular nerve group block versus fascia-iliaca compartment block, that is PENG versus FICB in hip and femur fractures in the emergency department. So this was a propensity score matched cohort study where we have compared a PENG, that is a newer type of nerve block, versus FICB, which was a conventional nerve block given for hip and femur fractures. Why hip and femur fracture? Hip fracture is one of the common conditions where patients are presenting into the emergency department of trauma, and these patients are staying in the yellow area of the emergency department with pain. Even after adequate anesthesia, the patient's pain is not getting controlled. That's why we started working on PENG versus FICB. So yes, as I have mentioned, it is a common condition in our trauma emergency, and multimodal anesthesia, as I have previously mentioned, it is always necessary. So what were the ultrasound guided nerve block options we had? We had earlier, it was the femoral nerve block, but femoral nerve block is very, it was the safety concerns were there, because if you are giving a femoral nerve block, the chances of damaging the femoral nerve physically was very high. That's why over last 15 years, the standard of care was FICB, that is fascia-iliaca compartment block, which I will show. So FICB, now for last 5 years, there are newer block techniques, that is PENG, that is pericapsular nerve group block, has come into the studies. Various anesthesiology journals and post orthopedics, post hip surgery case reports as well as RCTs has been conducted on whether FICB and PENG is equivalent or not. So we did a prospective analysis of PENG versus FICB. So what are we going to block here? If there is a patient who has come with a hip fracture, for example, superior pubic rami or inferior pubic rami, or there is acetabular fracture or a femoral head fracture or neck fracture or proximal femur fracture, in these cases, we have to, if for adequate anesthesia, we have to block the nerve groups which are around the hip joint and providing the pain supply to the hip joint. So what are the nerves? One is femoral nerve, another is obturator nerve, and another is accessory branch of the obturator nerve which supplies the hip joint here. What is a PENG and what is a FICB? So how we do this is just a schematic diagram of the ultrasound showing the cross section when we are giving a nerve block. So what happens in a pericapsular nerve group block? So the ultrasound probe is kept parallelly, the linear probe is kept parallelly to the inguinal ligament on the affected side. From the lateral to medial approach, we try to see the anatomically the femoral artery, femoral vein, femoral nerve, and we'll try to, the needle will be directed towards the iliac blade in between the anterior iliac spine and iliopubic eminence. So here, whenever we are introducing the needle will directly hit the bone, and slightly above it will give the local anesthesia. So here the pericapsular nerve group, that is obturator nerve, accessory obturator nerve, and the articular branches of femoral nerves are blocked. What happens in a FICB, that is fascia-iliaca compartment block? Here what we used to do, this is a volume block. Volume block means large amount of volume will be given. So again in the same cross section, we will come here above the iliopsoas muscle, that is fascia-iliaca, and the femoral nerve is here. So we give a block, the needle will reach here at a level where fascia-iliaca and iliopsoas muscle is there. In between that we will give a block here. What happens once we give a large volume block of 20 to 30 ml of local anesthetics along with the normal saline, this will seep down and block the femoral nerve. So how these two techniques are different? First thing, the learning curve. Learning curve of PENG block is very faster. The reason being, here there is not a lot of structures that is intervening, because only muscles and fascia are there. The serious neurovascular structures are safe because they are distant. Second thing is we are hitting directly to the bone. So we have a guard that, yes, once we are giving a pen block, the clinician who is giving a pen block is confident that, yes, I am also feeling that we are hitting the bone. But what happens in the FICB block? In the FICB block, the chances of damaging the femoral nerve or the neurovascular structure is higher because we are approaching nearer. Second thing is, here there is no physical guard here. So we are reaching here to the fascia, and so it is always not that easy to reach to this fascia and just target to this fascia iliaca compartment. Many times what happens, we just enter the needle and we reach the iliopsoas muscle, and many times the clinicians give the local anesthetics inside the muscle, not just below the fascia iliaca. So easier wise, PENG was found to be feasible as well as easier. So what we did, whether this novel technique that is PENG is efficacious or not, we tried to find out in this study. So again, PENG has an osseous supply. If we can see, the osseous supply is anteriorly as well as medial, and some of the posterior part of the bones are supplied, whereas FICB covers the anterior part of the bony supply. Second theoretical advantage that is published in the literature is that in the PENG block, the motor sparing is there. Once we give a PENG block, it doesn't affect the quadriceps muscles power. But once we are giving a FICB block, we are blocking the femoral nerve. So branches supplying the quadriceps muscles are also getting blocked. So the relative recovery from the relative recovery of the patients are usually found to be higher in FICB. So these are the findings which we are discussing about how PENG and FICB is different, although their indications are nearly same. So we try to find out a group like the patients who are having a hip fracture or a proximal femur fracture. We try to differentiate whether PENG and FICB is similar or not. So this study was done with an objective to investigate the efficacy of PENG versus FICB in traumatic hip and femur fractures in terms of pain control. And our secondary objectives were to compare the opioid usage in both arms, because that was one of the safety objectives, and to compare the adverse events in both arms. It was a prospective, non-randomized study, single center ED based in the Jayaprakash Narayan Trauma Center Emergency Department, conducted over a period of 1 year. We included patients, adult patients of more than 18 years who presented with traumatic hip or femur fracture, acute presentation, and who were eligible for ultrasound guided nerve blocks, either FICB or PENG. The eligibility criteria for nerve blocks in our emergency department was if the patient is having the femur or traumatic hip fracture, if the patient's pain is not being controlled even after adequate IV opioids, and the pain is still remaining more than 7 out of 10, and the patient is not posted for emergency surgery, in consensus with orthopedics team, we gave the block for this proximal femur or traumatic hip fractures. We excluded patients who had contraindications to nerve blocks, like for example, local site infection, any open fractures, chances of compartment syndrome in patients, or the patients who had allergy to the local anesthetics. We excluded patients who didn't give consent for this blocks. So coming to the treatment arms, PENG was the treatment arm, the control arm was FICB, and we allocated on the discretion of treating physician. That's why it was a non-randomized type of study, and the treating team were emergency physicians trained with ultrasound guided nerve blocks. How we assess the endpoint? We assess the endpoint using visual analog scale. Visual analog scale is one of the objective parameter on how we can assess the pain control, and pain assessment was done where in the scale 0 means no pain, which ranges to the worst possible pain, that is given a score of 10. The patients who are having a score of 7 or more are considered as very severe or severe pain group, and even after giving the IV fentanyl or tramadol or opioids, if the pain is not being controlled, we gave FICB or any of the nerve blocks. So how we did the pain assessment? Pain assessment was done just prior to giving the block, that is 0 minute, 30 minutes after, and 60 minutes after giving the block. We tried to calculate what are the rescue opioid uses after the block within next 12 hours. If the patient is having a breakthrough pain, if the patient has asked for, or there was a requirement of IV fentanyl or tramadol specifically in next 12 hours of giving the block. And we tried to find out whether there are any other adverse event that has happened, for example, block site infection, vascular injury, systemic toxicity, or any side effects related to opioids. So what we did, as I mentioned earlier, it was a non-randomized type of study, although it was a prospective study, but it was a non-randomized study because the emergency physicians, it was that at the discretion of emergency physician that the patient will be allocated to FICB arm or the PENG arm. That's why to at least curb some of the selection bias, we did a matching. So what we did here is like we did a propensity score matching, which is a type of matching of case or controls or matching of two arms in a non-randomized study. What we do in this propensity score matching is like, for example, there are a lot of patients in this arm and this arm. For example, PENG and FICB arm. We calculate a propensity score of each of the patients on the basis of whatever confounders we think. For example, here we have thought of earlier that age might be a confounder, gender might be a confounder, and indications. What are the indications of PENG or FICB? So, according to the confounders, there will be a calculation of a propensity score, and propensity score of one patient will be matched with the another patient of another arm. For example, in a treatment arm PENG and FICB, the propensity score will be matched, and accordingly we'll be doing the matching. So I'll show you the flow diagram. So 333 patients received the peripheral nerve blocks over last 1 year during the study period, of which 185 were excluded majorly because they had been the recipient of other peripheral nerve blocks. So overall 148 were included for the study. After missing information removed, 104 patients were included, 52 in each arm, unmatched analysis in FICB and PENG. To remove or cause the selection bias, we did a propensity score matching. So at the end, 24 patients in each arm, that is 24 pairs of patients are only there in FICB and PENG arm. So coming to what happened after matching 24 in each arm, what we found out that the indications of giving block was nearly similar in both the groups. Age group was nearly similar. It was more of a younger age group. Males were more. In-plane and out-of-plane approach were similar, and drugs used for the nerve blocks were also similar in both the arms. Coming to comparison of the pain scores. So this was one of our objectives, that the FICB and PENG, how they are efficacious in terms of pain control. So what we did, this was the comparison of pain score according to the visual analog scale. So on the y-axis, the pain score is written. On the x-axis, first group is pre-procedure, second group is 30 minutes after the block, and third group is 60 minutes after the block. So what we did, this blue box and whisker plot shows about FICB pain, and this is of the patients who are given the PENG block, pericardial nerve block. So it was found that across the time, the pain has reduced pre-procedural 30 minutes and 60 minutes. But when comparing in between both the arms, that is PENG and FICB, we found out that there were no difference. So PENG was found to be equally efficacious in terms of pain control when it was compared with the FICB arm. Coming to our secondary endpoints, what we tried to find out is like, is the patients who are allocated to PENG or FICB arm, is there any differences in opioid usage, the breakthrough opioid medication usage? Sorry. To standardize that, we have used IV morphine milligram equivalents, the fentanyl or tramadol that has been converted to the morphine equivalents. So we tried to find out what are the doses that was required in the PENG arm. In the PENG arm, 12 mg was the median dose of opioids that was required, whereas in FICB it was 14 milligram, and there was no significant difference in the opioid usage in both the arms. And none of the patients had reported any of the adverse events related to the ultrasound guided nerve blocks or the opioid usage. Coming to what literature says, obviously this is one of the studies from our emergency department, but what literature says, multiple studies have been conducted over last 4 and 5 years related to hip surgeries. The patients who are undergoing hip surgeries electively, the Department of Anesthesiology has published a lot of papers on either PENG or FICB, which is better. So this was one of the study, one of the meta-analysis conducted in 2023 by Ng et al. Of 6 randomized control trials on the pain at 6 hours, 12 hours and 24 hours, and it was found that PENG and FICB is equally efficacious in controlling the pain for patients who are undergoing hip surgery and post-hip surgery for pain management. Coming to another meta-analysis of 6 studies about the morphine equivalents, it was found that the meta-analysis suggested that in the patients who are receiving the PENG block, the opioid usage is slightly less as compared to the control arm, that is FICB, although it didn't reach the statistical significance. So maybe further larger studies will be necessary. And this was the same case in our study also, that 12 milligram was the median dose and 14 milligram was the median dose in the FICB. So our study was not devoid of limitations. It has some limitations, like it was one of the earlier study, but it was a non-randomized study. So we are planning for a randomized controlled trial further. It was a single center study, contained smaller sample size. Earlier 104 sample sizes included, and because of the propensity score matching, we could include only 24 in each arm. So that turned out to be 58 sample size. And motor power was not assessed. Earlier, theoretically, there was a benefit that motor power is preserved in a PENG block as compared to FICB. In FICB, quadriceps muscle weakness is common. So, if we are discharging the patient, or if the patient is being discharged out of the hospital also, if the motor power is blocked, then chances of recovery or length of hospital stay might increase. But in our study, in this study, we have not assessed the motor power, which can be incorporated in the future studies. So, concluding our study, that PENG block is similar to FICB block in hip and proximal femur fractures in terms of pain control, in terms of rescue opioid use, and adverse events. So, what we have discussed now is, like, we have discussed about the use of ultrasound guided nerve block, the block on arrival concept, the concept of pain-free emergency department, specifically for trauma settings. But can it be used in non-traumatic settings also? As I have shown some case reports that it can be used in cardiac arrest for calming the ventricular storm. It has been shown in one of the case series that it was used in acute or chronic pancreatitis related pain. So I invite my colleague Dr. Satyendra to discuss about the management of acute pancreatitis and ultrasound guided nerve blocks. Thank you.
Thank you, sir. So today I'm here to talk about a recent research project that we have concluded in our department, where we tried to compare the efficacy of erector spinal plane block versus conventional pharmacotherapy for alleviating pancreatitis pain in an ED. So first, a brief background about our study. Pancreatitis is the most common gastrointestinal complaint requiring admission from the emergency department. The most frequent complaint of pancreatitis is severe abdominal pain radiating to the back. Traditionally, opioids have been used as analgesic agents, but they have serious side effects such as hypotension, respiratory depression, and as Ankit sir talked about, the persistent opioid use disorders. Other than that, there are other studies as well showing a Sentinel survey which reported that 59% of the opioid users had their first opioid use after a prescription from a hospital. And out of those 59%, 31% prescription were from the emergency department. So going forward, you have to be careful, and that's why this opioid sparing analgesia is coming in trend these days. Another modality for pain management in acute pancreatitis is celiac plexus block. Although it's not routinely used, and it's also not strictly recommended by American Journal of American Gastrology Association, although it has been found effective in controlling pain, intractable pain in acute and chronic pancreatitis. So these were the traditional approach that we had. But recently, erector spinae plane block has been described, which is a novel method for analgesia in cases of pancreatitis. Although there is no randomized control trial to prove the effectiveness of this technique on analgesia and compare its analgesic effects with conventional pharmacological therapy. So a brief overview of erector spinae plane block. It's a form of regional anesthesia technique targeting the interfacial plane between the erector spinae muscle and transverse process of the vertebra. It was first described in 2016, and in the last 8 years, it's been one of the most heavily researched topic, having more than 1200 publications, which means like there's roughly a third research paper coming out every third day. The proposed mechanism of action is through local anesthetic spread to paravertebral and epidural spaces, blocking dorsal and ventral rami of spinal nerves. Although it's just been hypothesized and there are multiple hypotheses about its mechanism of action and no clear mechanism is known. Erector spinae plane block has been used in many conditions. It can be given till high thoracic level till lower lumbar level. So it can be used in conditions if someone is having a shoulder replacement, and there have been reports where people have used it even for hip replacement. In medical settings, it's used for pain control in pancreatitis, cholecystitis, hepatobiliary cancer, and there's some case reports showing pain efficacy even in renal colic. The advantage of erectus spinae block compared to other forms of celiac block is that it provides effective visceral and somatic pain relief with very minimal systemic side effects compared to opioids. Here, you can see the procedure is easily done in an emergency department where the performer stands there and the patient is kept in prone position. The patient can be kept in supine or lateral position as well based on their comfort. And the important thing to note here is that to keep the performer, probe, and the picture in line. So you have a clear view of what you want to, where you want to give the block. Here is a sonoanatomy picture of the transverse vertebra. This is the T7 transverse vertebra where we are interested in giving the block. So needle is transferred through the skin, subcutaneous fascia, and the erectus spinae muscle, and there we find the interfacial plane where the local anesthetic spread happens. So coming back to our study, the primary objective of our study was to assess the efficacy of successful analgesia, which was defined as a DVPRS score, a defense and veteran pain rating score of less than or equal to 3, after 6 hours of intervention in both ESPB arm and conventional pharmacotherapy arm. And along with that, to look for drug or procedure related adverse event in both arms. The secondary objectives were pain score assessment at different time intervals over 24 hours, the patient control analgesia pump matrix, duration of successful analgesia in both arms, the total time taken for the block procedure, and patient feedback based on Likert scale. Material and methods used. The study was designed to be a prospective open label parallel phase 2 randomized control trial. The place of study was AIIMS Emergency, New Delhi, and the study lasted for a period of 18 months, starting from March 2023 to concluding in August 2024. The study population were patients aged 18 to 65 years who presented to ED with pain related to pancreatitis. And the sample size was set at 60, 30 in each arm. Patient selection and randomization. So adult patients who were already a diagnosed case of acute or recurrent acute pancreatitis who were presenting to ED with severe abdominal pain, which was defined as a defense and veteran pain rating score of more than or equal to 7, and the patients who were willing to give consent. The important exclusion criteria were patients who presented with hemodynamic instability, patients who had one or more organ dysfunction, and patients who had significant comorbidities like chronic kidney disease, chronic liver disease, and congestive heart failure. Patients were randomized on one-by-one basis using a random sequence generated by web-based software. And the allocation concealment was done through sequentially numbered opaque sealed envelopes. Now, here it's important to understand what we actually did in each arm of the study. So in conventional pharmacotherapy arm, we used injection tramadol, 50 mg every 8 hourly. Here, the reason for choosing tramadol over other opioids was because there was first we find a similar study where they had compared erectus spinae with conventional pharmacotherapy, and there they used tramadol along with PCM. On top of that, we also connected the patient to a PCA pump, which has been recommended by American Gastrology Association as the ideal pain management for pancreatitis patient. The PCA pump was filled with a fentanyl infusion at a dilution of 10 microgram per ml. And after that, there was a continuous infusion ongoing at 1 ml per hour. The demand dose was set at 15 microgram, and there was a lock-in period of 10 minutes, which meant that a patient O in an hour can only be allowed to have 4 maximum doses. While in the ESPB arm, bilateral erectus spinae plane block was given with 0.5% bupivacaine at 2 mg per kg, along with dexamethasone 8 mg. It was filled with 20 ml of NS or the dose whichever was seen appropriate to make it 30 ml on each side, as this is a volume block. The reason why we chose to add dexamethasone here, as there has been a meta-analysis which showed that use of dexamethasone prolongs the efficacy of plain blocks while given. Similarly to the conventional pharmacotherapy arm, patients were connected to a PCA pump which had the same settings. So during the period of 24 hours, in spite of all the interventions, if the patient still complained of pain, then rescue therapy with IV fentanyl 50 microgram was given. Here's a consort flow diagram for our study. In total, 87 patients were assessed for eligibility, out of which 27 were excluded, 24 did not meet the inclusion criteria, and 3 declined to participate in the study. And 60 patients were randomized, 30 in each arm. All patients were followed up, and the analysis were done for all patients. There was no attrition in our study. Coming to results and analysis. Here are the baseline characteristics of a patient. As you can see, in both the arms, patients lie in the 4th decade of their life. The gender distribution is fairly equal, and the weight distribution is also fairly equal. Pain at 0 hour is comparable. So pain score over time in both the arms. Here, as you can see, the blue line denotes the ESPB arm and the red line denotes the CPT arm. The boxes denotes the median score and the vertical line denotes the interquartile range. So right from 1 hour, there has been a significant drop as the baseline was comparable, but right after 1 hour, there has been a significant drop in the ESPB arm compared to the CPT arm. And this median value stays lower than the CPT arm over the period of 24 hours. In the period of 24 hours, all values are statistically significant. The pain reduction is most significant during the first 18 hours, and after that, there is some overlap between the ESPB and the CPT arm. So our primary objective, assessing pain at 6 hours, here we can see that the duration of successful analgesia, patients reporting DVPRS less than or equal to 3. In the ESPB arm, 97% of the patient had achieved successful analgesia at 6 hours, while only 43% of the patient achieved successful analgesia at 6 hours. Another metric that we were interested in was PCA pump metrics. Here you can see that the total number of PCA attempts made in the CPT arm is significantly higher. There are roughly 10 times the number of ESPB arm. Also, the number of successful attempts is roughly 7 times. But the most important thing, the fentanyl consumption, it's roughly 5 times higher in the CPT arm compared to the ESPB arm. All these values are statistically significant. So pain despite therapy, total number of this graph represents the frequency of total attempts made by each patient. Here, it was important to understand. First of all, the blue bar represents the CPT arm and the green bar represents the ESPB arm. Here you can see a dotted line. This dotted line is the line of safety lock-in. So if you remember from our PCA pump, we had arbitrarily set that 4 attempts could be made in an hour. That means over a period of 24 hours, total 96 attempts could be made. Here, in the CPT arm, there were 43% of the patient who, in spite of making the 96 successful attempts, they still were asking for more fentanyl doses. And these were all unsuccessful attempts. So, in spite of having full therapy from tramadol and fentanyl infusion, 43% of the patient remained in pain in the CPT arm, while there was only one instance of such case in the ESPB arm, and this was a case of block failure. Duration of successful analgesia. Again, the way we defined successful analgesia was defense and veteran score less than or equal to 3, and the duration was described based on the 6 parameters that we were measuring. So the pain was initially assessed at 0 hour, then 1 hour, and after that every 6 hours. So if someone reported of pain, say DVPRS score of 2 in the CPT arm, so till the next time the patient was evaluated, that was at 12 hours, the patient was considered that they were having successful pain alleviation. And that is how duration of successful analgesia was calculated. Even though this method may not be very accurate, but still, like the findings that we received, that in patient in the ESPB arm had spent more than the double the time having their pain successfully alleviated than compared to the CPT arm. Now, an important performance metric for any emergency is the total time taken for the block. As in emergency, we don't have time to do a lot of stuff, so we have to prioritize everything. So in our study, we found out that the median time taken was 8 minutes. Here, there's a wide variability going from 5 minutes till roughly 16 minutes. But it's important to note that 50% of the blocks were given between 6 to 10 minutes. Even though it may be a small sample size, but still it's significant that 50% of the blocks could be given between 6 to 10 minutes. Also, while comparing it with other studies, there is some study by Sobi et al. It's a study published in 2019 where they gave that the average time taken by them was 8.2 minutes. But it's important to remember that it was done by anesthetist and controlled settings, while our study was still done by an ED resident in the emergency department. But still, we got comparable times. Now, the most important metric for the quality of an ED is the patient feedback. Here you can see that majority of the patients in the ESPB arm were very satisfied with the treatment, while more than half the patient in the CPT arm were either neutral or dissatisfied with the treatment. Now talking about the safety outcomes, we did not have any significant adverse event related to ESPB like pneumothorax, local anesthetic systemic toxicity in our 30 patient, and there was no significant adverse event related to tramadol use in the conventional pharmacotherapy arm as well. While we got good results, and maybe for the skeptic the result might be too good to be true, we had some strengths in our study, but there were also a few limitations. First of all, it was a single center study conducted in a tertiary care ED. And again, we had a relatively small sample size. The way the study was conducted, it was hard to get a blinding done, so it was an open label study. And all blocks were performed by a single performer, which will again suffer the extrinsic validity of the study. And also, only clinically stable patients were recruited in our study, which means these results can't be generalized for patients who may have severe acute pancreatitis. So in conclusion, we can say that erector spinae block is a safe, efficacious, and feasible alternative to opioid analgesia for acute pain management in pancreatitis. It is safe based on our study, efficacious as over the period of 24 hours, patient in ESPB arm had better pain scores, and feasible because the time taken during the ESPB block was comparable as done by an anesthetist. It provides superior analgesia and is opioid sparing, which is one of the most important findings from our study and leads to higher patient satisfaction.
Thank you, Satyendra. So, concluding our clinical grand round. So, our concept was block on arrival, redefining the pain management in the emergency department. What we have discussed is all the types of blocks that has been done in the emergency department. So, I request Dr. Bhoi to conclude the pain management in the emergency.
Thank you, Dr. Ankit. You saw the journey of pain-free ED concept, which was generated, concept brought by AIIMS Emergency Department. And this concept, it's a journey. So how to set up the same theme across emergency department across the country. So first of all, you should identify a local champion among your faculty who should train hard and lead by example to create a pain-free ED concept and create an ecosystem so that you address pain on arrival. That is the first and foremost. Second thing, ecosystem means creating a team, creating the logistics, logistics in terms of material supply, the machines, the drugs being available round the clock. Inculcating the habit of safety first before the block. There is a concept called as stop before the block. Giving block is important, but the more important thing is safety of the patient safety. So you should arrange near a crash cart with intralipid emulsion for any evidence of local anesthetic induced systemic toxicity. Second aspect of creating this program in your emergency department is training your resident hard. So because this is a round the clock service for, for getting a good goal. So every resident has to train, train and train. They should undergo workshops, both in phantoms, in cadavers, and after then only certain number of block, they should undergo supervised, giving block, like we do other procedures. And to start with, they should start with least, dangerous block, such as volume blocks, plain blocks, such as erector spinae block, serratus anterior block, where you're not going near the nerve. And you can start giving the blocks there. And then you should graduate slowly. That is what we did in our department also. Then last 3 years, we have been pushing hard the block on arrival concept. Before that, we were doing blocks. I was doing blocks along with my faculty, then kept on training over last 15 years, the residents who are on the floor. Then emergency medicine department came. Before emergency medicine came as a specialty, we already started practicing in the ER. So last 3 years, that means block on arrival, round the clock somebody is giving block. That is the concept. How to generate, in the department, the culture of block is giving them thesis. Giving them thesis, we gave thesis to our residents so that it is ingrained in their DNA of giving blocks. Okay, a pain-free ED, addressing pain is one of the fifth vital sign in the emergency department. Equally important, like your TPRVP. So that was also done. Now, if you see that our second year residents have started giving blocks. So that means the journey has become better and better. And the same thing, the block which we did, it has been the anesthesia's domain over the years. But for addressing acute pain and procedure, acute pain service on the front line, block on arrival means arrival in the hospital. The first contact is emergency department. That is the meaning of block on arrival. Not that you give it within 30 minutes or within this thing. You have to research the patient. Then the pain comes. So this is the shift. And when we led by example in this, we see the lot of papers, evidences came. Dr. Ankit and Dr. Satyendra has put a lot of evidences we generated during our journey to prove a point that emergency medicine physicians can practice block on the arrival. This is also creating pathways in our country. Okay, it is like going against the wind. Same thing happened in point of care ultrasonography. Now you see every emergency department is actually using like a visual stethoscope. They are doing research, there is a clinical care, pathways, and they are making strides last 15 years. That is one. We are proficient, and it all began at AIIMS Emergency Medicine Department. And once we did that across the country, Southeast Asia region, globally, our emergency medicine department point of care ultrasound program is a runway hit across the globe. We trained the American residents on point of care ultrasound. And then while we're doing, this was the journey which we took. Because you have to be first proficient on focus. Then only you can achieve a nerve block. It is high skill. It is not a skill very easy. Because it comes with safety of the patient. Direct. Other you are not doing intervening. You are doing a fast scan, you are not intervening. It is helping you to take decisions. So the message is be proficient. And now you see most of the residency programs, now they have adopted blocks, ultrasound guided blocks in their emergency department. So that means in the last 15 years, we're able to create ripples of this new concept brought to emergency medicine, which is for patient-centric approach. So this is how you develop a program, you do research, give thesis, and newer blocks it will come. Every day some new block in the new kid in the block. The new kid is stellar ganglion block, which Ankit just said about it. Like addressing ventricular arrhythmias, refractory ventricular arrhythmia, the electrical storm. So this already in our department, right from the peak of COVID, where we gave the first stellate ganglion block to the Now almost we have done 20 out of that stellate ganglion block at the electrical storm. And if you see that it is now catching up, slowly this learning is catching up in few other departments and stories. And if you see the latest blog to all my emergency medicine residents and colleagues across the country, because it is being live, webcasted live across the country. So I'd say that you can go to MCRIT blog and you see the major, one of the hot topic is stellate ganglion block in electric, as a treatment of electrical storm. Like SCAPE came as a hot topic from our department. The next hot topic is stellate ganglion block. So it can be done and it should be a practice. That is the main theme of this clinical grand round, that whatever good practices which we generated at AIIMS Delhi should be translating through across other emergency departments across the country. So I know if there are any questions you'd like to take as a group before we finish, we still have some time for any questions. Yes. Professor, you want to ask any question? Dr. Nair?
So, basically, when we are plotting pain in and around the hip joint, whether there is fracture something there, so you have multiple options. And the main concern is the safety of the procedure, that you are not actually, just like pen block. Pen block is relatively safe because the arteries and nerves are slightly a bit from the side. So if you see the R result, it is almost comparable.
Yeah.
So why it is comparable, sir? So is there any more complication regarding nerve injury or the arterial injury?
Yeah. So what I'll say is, if you see, you said there's a comparable in the terms of, because the adverse event also, it was comparable. But procedure-related adverse event, we didn't look into that aspect, here. Though we didn't have anything, but if you see in fascia iliaca compartment block, you are just going near the femoral nerve and just piercing the fascia, giving between the muscle and the fascia. And femoral nerve is nearby. And some vessels, small vessels, they come in the pathway. You have to avoid them. So that is one aspect. Second is, if you see pen block, in the pathway there is no vessels only. They divide of any vessels or not directly. So you can go straight away, and hit the bone, rotate, slightly withdraw and give the block. So that is the advantage of pen block, and you can do it in a quick time, much quicker time than FICV. FICV you have to be very cautious. Go slowly and then you take some time. Am I hitting the nerve? Am I hitting some vessel? Put the color. In the pathway, is there any vessel I should avoid? You have to take care of it. That point we are discussing. We discussed everything. And while you do pain, nothing in the pathway. You can go straight and hit the bone. So it is easier, much safer, and more effective as well. More effective. Plus, it is purely sensory. And FICV, it has got some motor component. Those patients where you're going, suppose you are wheeling into the OT directly. Any patient, hardly orthopedician, they send the patient to the OT immediately. But suppose somebody is planning OT that day. For example, after 4 to 6 hours, you have given the block. So you should avoid giving blocks. One caveat is, you should have it in the protocol place. We don't give blocks those patients who are going to the OT within 6 to 8 hours or 12 hours in the ED. So that is, these are the 2 points is very important while considering which block you want.
Another question to Satyendra.
Satyendra.
Director is finding block, same block. Was there any failure? You said that there is one failure case. There is only one failure. So, and you have also discussed that dexamethasone is probably better than giving, when you mix with dexamethasone, the efficacy is pronounced. So, have you tried with
You can come over.
those?
Come over there. Bring webcast.
No, sir.
Any specific reason you chose actually dexamethasone rather than?
With dexamethasone, there was already some evidence behind it. Like in 2019, they did a meta-analysis, and also like the case report that we had on pancreatitis. At that time, we used dexamethasone with bupivacaine and levocaine.
we can also use and it increases the efficiency and it prolongs the effect of the local anesthesia.
Yes, sir. But in volume blocks.
No, you're right, Dr. Nair, that when we use a lignocaine, we generally use lignocaine with ADR mixed. Generally, we use that. In bupivacaine, there is no mixture like that when we gave. So that is one reason we did not give. Other, if you have chosen purely lignocaine with ADR, it is preferable. Plus, with that also you can add dexamethasone to still prolong the duration. Our all effort is to prolong the duration because we are giving a single shot block. Suppose you are giving a catheter. The next step is the limitation of this study was. So main thing of this, we want to break the pain cycle so that you can do away with smaller analgesics and all that with the patient this thing because they are intractable pain they are in. The best thing next step is to try with a catheter. Put a catheter, Fellingness technique, and let the infusion continue for next 28 to 48 hours till the patient start taking orally, and then you can do that. So that thing next study we can plan, maybe a thesis or maybe so we can give and try to see. So that is the thing. But DEXA still it increases all this thing. This we came to know when we published our case series of 8 patients before prelude to this RCT. So that was based on that experience we started. Any other question, Shahana? Yeah. Be a bit louder because it is backcasted. Huh?
Can I go on to give a block one more time? If I can, then how much time should I wait, or it's preferable that I don't do it?
See, block failure you should immediately, it is better to avoid. Immediately better to avoid. So you should give a washout period. There is no straight answer to that, but try to avoid at least for at least 4 to 6 hours. You have given there is a partial response, right? That means there is block failure. Don't try with that. You give a rescue medication because patient will be in pain. Suppose there is a block failure, you should know which is the rescue analgesia. You should predefine your rescue analgesia. Or in this case, you can give fentanyl. Okay? And then you can try when the washout period is there. Then you try again because otherwise it will lead to cumulative toxicity of the drug. The basic thing you have to be very safe while calculating the drug. Okay? So totally, if there is no response, that is also block failure. That means there is no block only. You have not, suppose you are not able to even have a little bit of pain relief. That means the drug has been deposited in the muscle or somewhere. Then you can give it immediately. Okay? If a partial relief is there, 20% relief, that means you are failure. You have given the block, did not have any action, that means you are not acted only. You can give it again. Right? I hope I answered the question. Any other question on this side? Okay. So if you see, the last message is smaller nerve blocks. Start practicing smaller nerve blocks, peripheral nerve blocks is the in thing because it consumes less of local anesthesia, more targeted approach of analgesia. Suppose you have a hand injury, so you should give median nerve block, ulnar nerve, radial nerve, depending upon which zone it is. Similarly, in the foot also, you can give peripheral nerve block, okay, like sural nerve, smaller nerves, deep peroneal. So they will consume less, very targeted and very successful, okay, impaired objects. Okay, what the thing is, where people practice less in emergency medicine literature is facial blocks. Okay, Tintinelli has a beautiful picture also. So if you are repairing something on the face, use facial blocks, right? So there is no into story, though this is actually the story which has begun and which has begun. The last block which you should practice, once you get proficient, like a very well proficient, is try brachial plexus block. Okay, but not at the residency level. Okay, so once you are very proficient, you already given 100 blocks. Go and start. The last one you should try is the brachial plexus. But we started the whole journey in our ED started with brachial plexus when I started with the bracelet.
Worldwide, sir.
Yeah, my personal experience, emergency department, brachial. Anesthetic, they do great. They are great in doing blocks, this thing. But ED literature, This is how what I feel is we should go. So I thank all the participants and the faculty to listen to the story of block on arrival from Department of Emergency Medicine. I thank my colleagues, Dr. Ankit Sahu, our newly joined assistant professor in emergency medicine, Dr. Satendra, our third year postgraduate resident, who has presented these papers. Both were presented in, one was presented on in US in the American College of Emergency Physician meeting. The second was presented in Australian Emergency Medicine meeting by Dr. Satendra. I congratulate both of them, and both are underway of publication. Thank you very much for listening.